The second part is Hilar biliary duct stenosis, how to choose ERCP and PTCD. Treatment of the Hilar by duct stenosis is very difficult. Choose the appropriate method is also very important. We have two common methods, ERCP or PTCD, how to choose. This article compared two techniques for the treatment of the Hilar lesion. Both techniques are recommended. They have a similar technique success rate. The authors concluded: the first, proximal biliary obstruction PTCD or ERCP both are okay. The second, the distal obstruction. Authors prefer the ERCP technique. The conclusion is that the PTCD is a recommended standard of the palliative care for the case of obstructive jaundice, as it improves quality of life with definite immediate survival benefits. This article is very interesting. It's about the predictive factor for the failure of stent placement for the treatment of malignant Hilar biliary obstruction. They also find a large angle is identified as the predictive factor. It's noteworthy that the total of 2 patients received ERCP, but stent placement failed in 13 patients, accounting for about 21%. That shows the ERCP not perfect. This is another study on the treatment option of the Hilar by duct stenosis. The patient was classified into 4 types. Especially for Bismuth's 4 types structure, the success rate of the PTCD was very high, up to 82%, much higher than the 58% of the ERCP. They also gave the conclusion is that endoscopic and percutaneous biliary drainage are both effective methods for the palliative treatment of the patient with a Hilar tumor. However, the Bismuth's 4 types structure percutaneous drainage or PTCD proved to be safer and more effective. I would like to briefly introduce thinking a preliminary practice of our team on the topic of the intrahepatic bile-duct recanalization. This study is a poster in ASCO last year. The study suggests that the patient with advanced ICC, the combination of the chemotherapy, TKI, and anti-PD-1 and the PD-L1 agency can be prolonged the survival time of the patient. For this article, we can saw the OR was 80% and the DCR was more than 90%. 1 year OS is more than 72%. According to the results of the previous literature, it can be predicted that the survival time of the advanced ACC will be greatly prolonged. Internal biliary drainage become more and more important. How to conduct the internal drainage for stenosis, ERCP, and ERCP is also a treatment technique. And EUSPD can give the intragastric drainage of the left hepatobiliary duct. Another choice is a surgical operation, but both of these 2 techniques is not perfect. Another choice is reconstruction intrahepatic channel. Let's review the 3 other techniques. Tips: establish the channel between the hepatic vein and the portal vein in the liver. EPAS: establish the channel between the stomach and the small intestine. USGBD: establish a channel between the duodenum and the gallbladder. They have the common characteristic that they all establish a new channel and they are all transboundary technique. Thinking about the technical detail, we have a triple guarantees. Three-dimensional space of the intrahepatic bile duct give us anatomic accessibility. Number two, the PTCD can connect two intrahepatic bile duct and give us technical support. The third, the drainage tube or stand, plastic or metal stick stand can be used as a support for the reconstruction of the plan. This is one of the cases we did and show how to reconstruct the connection of the two left intrahepatic bile ducts. Column graphic shows the connection of the upper and the lower duct in the left lateral lobe of the hepatic. But the guide wire could not connect the two bile ducts. With the gooseneck catheter and the two bile ducts respectively, adjust the puncture angle. The puncture needle passes through the two cycles, and then enter the superfine guide wire and capture it with the gooseneck catheter, and then establish a new channel about the two bile ducts. Then the stand was placed to establish the internal drainage. Ultimately, to cater for the clinical requirement, ultimately proposed the concept of the intrahepatic biliary recanalization and provide a feasible procedure or technique.